Welcome to the anti-epileptic drug lecture. I'll start just by talking a little bit about epilepsy and the different types of seizures, since it's pretty relevant to how we treat them. Epilepsy is definitely a specialty area when it comes to practicing. Usually you're a neurologist that specializes in epilepsy or have specialized in that area somehow. But it is a relatively common illness, so you'll certainly see it in a variety of different practice settings, or at least see the medications. I think it's pretty applicable to most people to at least have a good understanding of kind of the more common ones. And then we'll talk briefly about some of the more unusual ones. So in America alone, more than 2 million people have epilepsy. About 1 in 26 will develop it. Treatment response is okay. About 50% of patients can actually be treated with just a single drug, which isn't too bad. But once you get further than that, it's difficult. So, I mean, with multiple therapies, you might only catch another 20% of people. There might be cultural or global stigmas associated with epilepsy and the treatment of it. I know that there are some cultures that view it differently than traditional Western European culture that we might have in the United States or see more commonly in the United States, but it's certainly depends on where you live around the globe or what communities you live in within the United States itself. 10% of people worldwide will have a seizure during their lifetime. However, epilepsy is defined as 2 or more unprovoked seizures specifically. So there can be a lot of other causes of seizures that aren't necessarily epilepsy. Most types of epilepsy are idiopathic. But there are genetic components, perinatal issues, trauma, stroke, infection, cancer, all types of different things that are considered to be precursor or causes of epileptic type seizures. Highest incidence is very young and very old, but we see it in all age groups and can significantly impact your lifestyle and ability to maintain a job, drive a car, those types of things. Okay, so seizure, we have a sudden change in brain behavior. Usually you have an over-excitatory response of some kind. And so there's different types of seizures listed here. Provoked seizure being maybe more surrounding things like metabolic or drug overdoses or drug-related things. So that's a seizure that you have a direct cause that was due to some sort of a outside influence that's happening. And so that's not really necessarily going to qualify as epilepsy. Psychogenic non-epileptic seizures, or sometimes referred to as pseudo-seizures, is kind of an interesting condition where you have a the physical appearance of an epileptic seizure. So you might have somebody who looks like they're in a full-on tonic-clonic seizure, but they actually, when they're EEG monitored, you don't see any brain abnormalities. And it's actually thought to be a physical manifestation of a psychiatric condition. So somebody with severe I'll just give an example of a guy who used to come into our ER all the time. He was severely agoraphobic, at least that's what they thought. But he would go, to a Target or something, and he would have a big seizure in public, and they'd call the ambulance and pick him up. And he was seen by multiple different epilepsy groups and basically fired by all of them because he doesn't really have epilepsy, and there's nothing they can do because it's all basically, when they break it down, it's all psychiatric. So some manifestation of anxiety or depression or something like that shows itself in a seizure type form. It's kind of interesting. Very difficult to treat these patients, especially if you don't know this history about them, because you would treat them like they have a seizure. You end up giving them pretty potent drugs to stop their seizure, and it might not actually work the way you intended, or it might just sedate them severely. And sometimes that can create a drug-seeking type behavior too, where people know if they get or fake a seizure or have one of these seizures come on, not that they're fake per se. Some people probably can't control them, but some people might be able to, and then they kind of milk the system that way. So that can be a tricky thing, and I've seen that in our ER as well. EEG is an electroencephalogram, in case you guys aren't familiar with that. And I don't know anything about EEGs. Here's something I stole from Mayo Clinic that shows different brain waves. And again, not my thing. But the point is that on an EEG, you can see when somebody's having a seizure. So the kind of cool thing about this is if you have somebody who's like we have a big neuro ICU at Abbott, and so people who are sedated and paralyzed even, you might not see if they have any seizure activity, but if they're recently involved in a stroke or some sort of other neurologic complication, they might be seizing regularly. And that's how you can tell that. Classifications, basically 2 major categories: partial seizures and generalized. Partial is a focal seizure, meaning it's taking place in a specific part of the brain, and usually there's varying degrees of what happens. So some people might not really get all that much impairment from it. Some people might have complete impairment from it. Some people might have some movement component. Other people might not really have like a jerky movement component at all. Generalized seizures is what you'd think about more as like a clonic or tonic abnormality where there's muscle rigidity or muscle flexation or both going on at the same time. In case you're curious on what the incidence is, you're looking at general seizures here, and generalized tonic-clonic, and then partial. So partial is by far the more common class of seizures if you're going to break them down into two groups, but certainly they're all pretty common with the exception of some really odd ones, like absence seizures are a little bit less common specifically, and they have a different treatment pathway as well. I don't want you to know anything on this slide, but it does show you a little bit of the differences in classifications, what comes along with a partial seizure, phases in tonic-clonic seizures, what generally you might see with that. So just in case you want to look at that or reference that, it's there for you. And of course, talking about the drugs. So I spent a little bit more time talking about the difference in seizures because it is pretty important when it comes to drugs. Now, a lot of the drugs we're going to talk about can be used for both partial and generalized seizures, but there are some exceptions there. So that's where we treat a little bit differently. AEDs have a bunch of different mechanisms of action, but they all kind of work in the same area of the brain with the exception of a few. And you can see all the antiepileptic drugs listed here for the most part, all the big ones. They're pretty much working on this specific type of sodium channel that works with brain receptors in the central nervous system, specifically NMDA and some other ones that I don't really care you know much about these. All I think about for the most part is their main mechanism of action is they block sodium channels, which makes it so this excitatory synapse here can't activate as frequently. And what you get is then a more inhibited response system and therefore less seizure activity is the overall goal. And there's a number of different ways you can do that. You can see that there's a bunch of different drugs that work kind of in the same channel. There's some drugs like levetiracetam which work within the synapse itself, or not, sorry, within the cell itself, not within the synapse. And then other ones that work kind of outside on postsynaptic areas as well. So depending on what you want to treat, you can mix and match classes. Now, the really interesting thing, I think, is we don't really care. So you might be on two different drugs within this category, but that's maybe gets a little bit more into the weeds. There might be epileptologists that would disagree with me on that, but certainly you can have somebody on lamotrigine and valproic acid. That's not uncommon. So just so you know, there's combinations within this, and you don't have to be like, oh, I have to pick gabapentin and levetiracetam and one from this group. No, you can pick multiples within the same grouping on this slide. This shows the other side of the coin. So one side of it is basically shutting down or suppressing the brain's ability to have an overexcitatory stimulation. And this one is potentiating the inhibitory system. So you have some sort of drugs in here that are somehow going to make your body have a more inhibitory response, which is going to hopefully shut down seizure activity. And so some of the drugs you'll notice might work in both areas, like here's felbamate, topiramate, zonisamide. Let's go back to that other slide. And you've got topiramate and felbamate, and I think zonisamide's up in here. So they might have a mixed mechanism of action there, which is kind of interesting. Doesn't necessarily mean they're better, but they might have a little bit more activity that's slightly different than some of their other drugs in other classes. Benzodiazepines we haven't talked about in detail, but they potentiate GABA. GABA is gamma-aminobutyric acid, and it is a major inhibitory pathway in the brain, and they basically enhance the brain's capability to do that, causing an inhibitory and sedative type effects. Okay, so I'm going to talk about the major drugs in this category. There are a few that are much more common than others, which makes it a little bit easier to learn, but these are all going to be pretty new. And I do suggest you spend some time getting to know them because, again, you'll see them quite often, no matter really where you work. So levetiracetam is Khepera. Khepera is probably the most common anti-epileptic drug. Now, again, people might argue with me on this because there's not really a set of guidelines that says you have to use this one first or whatever. You kind of pick from the broad spectrum ones and choose based on side effect profile. Khepera is technically a newer agent, but it's actually been around quite a while, probably 10, 15 years at least. It's generic. It's relatively inexpensive for the most part, but not not cheap by any means. However, it's got some nice attributes to it as well. So let's talk about it. Pros, one of the only anti-epileptic drugs that really doesn't have any direct drug-drug interactions. The reason that's nice is because so many other ones will talk about either are causes of drug interactions themselves, or they're prone to drug interactions because of their metabolic pathways. So to have a drug that doesn't really interfere with that whatsoever is really beneficial for these patients, because you can add Khepera or add to Khepera without necessarily having to worry about dose adjustments. Side effects, overall, it's probably one of the better tolerated medications out there. There certainly are some down here that I'll talk about in a second. It comes PO and IV, which is another really great advantage. So let's say you've got somebody who was taking Khepera on an outpatient, they miss a few doses, they go into a seizure, they come in, well, you can give an IV dose and get them instantly bioavailable Khepera into their bloodstream right away. And Khepera itself is actually useful to stop seizures in status epilepticus type situations. So lots of good advantages to Khepera. We also use Khepera really commonly at my hospital for any type of ICU seizure prophylaxis. So again, we're a neurohospital, neuro-ICU. People with strokes, hemorrhagic, ischemic, whatever it might be, they may be on Khepera as a prophylactic agent in the post-stroke period. And cons, it is twice daily dose. There is an XR formulation that is once daily, so that could be a convenience factor there, but otherwise it's not terrible, but it is twice daily. It is renally eliminated too, so people with renal dysfunction, you have to watch the dosing. And the biggest side effects are, one, sedation. However, this isn't reported very highly. And if you slowly titrate it up to dose, it's usually not seen. Usually sedation is seen if you start somebody on too high of a dose. Generally speaking, the body acclimates to this and people don't get very sedated on Khepera. And then the behavioral side effects. So these can affect up to 10% of patients. It's probably the most common group of side effects associated with Khepera. And you might see anger, aggression, irritability. These are used in kids too, so you might see different behavioral type changes with children. The question comes up sometimes is, do you give these to somebody with a psychiatric history, or would you avoid it? And I don't think it's worth avoiding in a psychiatric patient because it is such a good drug. It depends on how stable they are probably and how severe their illness is. So somebody with unstable bipolar or schizophrenia, I might not try Khepera, I might try something else. Somebody has relatively well-controlled depression, or even well-controlled like bipolar type 2 with hypomanic component, I would probably have no real problem with Khepera. So that's one thing to think about, just keeping that back of your head. There's no real guidelines or recommendations around that, but it's more of a case-by-case basis. But certainly it's not a contraindication to starting Khepera if somebody has a mental health illness or diagnosis. Next drug is lamotrigine or Lamictal, and this is another broad-spectrum agent. Oh, I should point out, so I've got these slides that say broad-spectrum. It's the interesting thing about anti-epileptic drugs, a lot of them got approved originally for pretty narrow indications. So they got approved for like, specific type of partial seizures. And then they got more use because what happens is a drug gets approved and somebody's like, well, I've tried you on these drugs. They're either too toxic or they don't work, or we need to add another drug. So, well, let's try this one. It's new. We don't really know. And then over time, we have a lot more evidence to say, yeah, these actually work really well for pretty much any seizure type out there. So these work, most of these drugs, the newer ones especially, and lamotrigine's another newer one along with Khepera, again, been around for 10, 15 years, but still kind of in the newer classification. And it's another one that was approved for partial seizures, and it's a very commonly used broad spectrum agent. Lamotrigine is another one that's really well tolerated if you start it appropriately. And there's a dosing titration thing that I've got here in a second, which is really all about how you start it. It's once daily dose. The half-life is about 25 to 33 hours, so it's a nice long-acting medication. Not renally adjusted, but if somebody has really bad renal function, you might just want to use caution and maybe get a level. Drug of choice in pregnancy, I'll put a little question mark there. There's some debate on whether or not this is true. For the most part, the evidence would point towards lamotrigine being one of the safer medications to use in pregnancy. So I have a slide on that, and we'll get to that in a second. I'll talk about some of the differences, some of the opinions out there, but this is generally thought to be true. Cons, the biggest con with lamotrigine is its slow titration. It takes about 2 months to get to a therapeutic dose, which is really difficult if you're trying to manage somebody's seizures. So you might have to do something differently in the meantime, or bridge somebody with a faster acting medication. Like Khepera will work basically within a day of taking it even orally, or you could load them IV and start them orally, and essentially you've got instant Khepera on board. You can't do that with lamotrigine. So you might have to bridge somebody. Maybe like for an example might be you start somebody on Khepera. And sorry, I say Khepera because levetiracetam is kind of a long word to say, but you start somebody on Khepera and maybe they start to develop some behavioral related side effects. Stop their Khepera, or you continue the Khepera because it's controlling their seizures and sort of work around the behavioral side effects while you titrate up lamotrigine until you can get to a point where you can remove the Khepera and keep the lamotrigine on. That might be a strategy or a reason why you'd use it. Or you start lamotrigine right away with the intention of keeping somebody on it. You use maybe one of the other drugs we're going to talk about for the first couple of months while you're titrating up. The reason why we titrate slowly is to avoid a rash or even, in severe cases, the Stevens-Johnson syndrome. So one of the things that comes up a lot with lamotrigine is if you stopped your lamotrigine and need to restart, how long do you wait? And usually we say like 2 days is safe to restart. Up to 4 is probably okay to restart at the previous dose, but any longer than that, and I would definitely go with a full retitration. Of course, that can be really complicated. So compliance with lamotrigine is really, really important. I mean, you have that little buffer window to miss a couple days, but any more than that, and you might put your patient at risk for a seizure and have to bridge them, and that's not that you would put your patient at risk. Sorry, rephrase. Patient puts himself at risk, right? But that's why lamotrigine can be kind of challenging to work with. Drug interactions, it does have some interesting dose requirements, but there's not really any direct cytochrome P450 metabolism, so it's sort of an interesting one that way. Other side effects, tremor, dizziness, some maybe movement disorders, usually dose-related. Once doses get higher, people experience more of this, but for the most part, again, it's one of the better tolerated ones. I'd put this one and Khepera as probably the two best as far as if you're going to start somebody on a medication for long-term use, which is most antiepileptic drugs in treating epilepsy. Either one of these choices is pretty good. Obviously, they have some pros and cons, but those are going to be the two more common ones that you see people started on and use long-term. Valproic acid or divalproex, the brand name for this orally is Depakote. It also comes IV as Depakon. Some people will think of this as kind of like the gold standard, but I think that's been not necessarily disproven, but that other drugs have been shown to be as effective as this medication. So I don't think this is really any better than another one. There's no renal adjustment needed, which is nice, and it does have a bunch of different formulations, including a long-acting once-a-day product as well. It's been around a long time. It's relatively inexpensive. Some cons associated with it: it's contraindicated in pregnancy, and it's an enzyme inhibitor, highly protein bound. So there's lots of drug interactions associated with it. Side effects, lots of side effects: tremor, alopecia, hair loss with patients' weight gain, blood dyscrasia type things, irregular menses. So this is not a super well tolerated medication compared to the other two we just talked about. It's also somewhat hepatotoxic and overdose. If you have somebody who's maybe psychiatrically unstable, probably not the best choice for them. It can be problematic if somebody decides to OD on it. Monitoring, looking at liver function, ammonia levels, and CBC, so it does require a little bit more monitoring than the other two, which essentially don't really require any monitoring other than asking them how their symptoms are going or side effects are going. So valproic acid is a fine choice. It just comes with more baggage than the other ones, and so for that reason, it is a fast-acting drug. You can give it IV. You can get it up to therapeutic levels fairly quickly. So from that perspective, you have the option to start this on somebody, but maybe transition them to something else. I don't think this is a viable long-term thing for a lot of people. Again, it's a super common medication, so I should say that. Take that kind of with a grain of salt, what I'm saying now. But the point is if you're deciding between a couple different medications, this is probably not your first choice, just because it's going to cause more side. It's more toxic than the other two we've talked about, and it's not any more effective. However, people might respond better to it, and you may have to consider using it. Topiramate or Topamax is another broad spectrum. Some studies might say it's a little weaker in its efficacy compared to some other AEDs, but overall it does work. Pros, it has weight loss associated with it, which might be a con, but if you had somebody who's interested in losing some weight, it might be an option for them. Some people refer to this drug lovingly or not so lovingly as Dopamax because it kind of causes this slowed thinking speech difficulty in up to 30% of people. So people just can't feel like they process information like they used to. And that's, of course, a major problem for most of the general population. So that could be difficult if somebody is experiencing that side effect. It is renally adjusted. It has cytochrome P450s. It's twice daily dosed. There's some other things here too, but the big one I think is that you're going to hear from patients is this, slowed thinking speech difficulty, which is fairly high incidence reported. Phenytoin is brand name Dilantin, and it's another broad spectrum one. It's one of the older drugs we're talking about within this group, but it's also considered for a long time to be one of the most effective medications for seizures out there. Comes as an IV form called fosphenytoin, or Cerebix is the brand name. And then there are a number of cons to discuss with this one. It's got a very narrow therapeutic index, and it's very highly protein bound, so meaning that doses are not necessarily going to respond in a linear way. I think I used this as an example way back in the fall, but it moves on more of an exponential curve as far as, like, let's say you're looking at somebody's blood levels and they aren't quite high enough. A doubling of the dose might be a quadrupling, or an increase of 8-fold of whatever you're trying to do, instead of just a simple doubling of the blood concentration, because the quicker you saturate any available protein binding sites, the more free drug you're going to get, and that's the most important. So getting levels is really important, making sure you're checking free levels especially if a person has low albumin, is malnourished, alcoholic patients, things like that. It does have lots of drug interactions. It's actually a CYP3A4 and 3A, some other 3A inducer. So it actually induces the metabolism of CYP2C and CYP3As. It's also metabolized by 2C, so it, interestingly enough, induces its own metabolism. But this is one of the drugs that you really do have to think about when it comes to, it's one of the very few inducers out there, and probably one of the more commonly used inducers out there. And inducers, of course, ramp up enzymatic activity and will cause other drugs to be metabolized more quickly. So if you're on another drug that's an antiepileptic drug and it's a CYP3A4 metabolized medication, you might have to increase your dose. And there's lots of guidelines out there on how to do this, so I'm not going to get into that. But in fact, if you look at like Micromedics or Lexicomp or some sort of drug database, they might give you dosing instructions like start the drug at this dose if they aren't on anything. If they're on phenytoin, start at this. If they're on valproic acid, start it here. So depending on the different medication combinations, there's lots of good information out there, fortunately for us, when we dose things, but at the same time, it makes things complicated as well. Side effect profile, again, this is a fairly toxic medication. It doesn't take much to get toxicity with it. High doses, you're going to see nystagmus, slurred speech, and ataxia. Generally speaking, people might experience some dizziness, drowsiness, maybe some hirsutism or hair growth in other places that they may not want it. Gingival hypertrophy, so gums kind of overgrow. Long term, a couple things I don't really care, it is teratogenic as well. So generally speaking, this is a medication that people will tolerate to a certain degree, but they might get, depends on how drowsy it makes them. It depends on how many of these more basic side effects they get. Once they get at a higher dose or slightly toxic on it, they might start to experience some of this. So it's not the easiest drug to dose, and it's not the easiest drug to maintain for long term just because of those toxicities and side effects, but it is used relatively frequently. I would say it's a lot less frequent now that we have a lot more established drugs like lamotrigine and levetiracetam out, but it's still definitely a player and an option to consider. Carbamazepine and oxcarbazepine are two different drugs, but they're essentially the same thing. They're kind of, even though the names don't sound quite the same, but they are sort of not necessarily enantiomers of each other, but they're similar compounds, very similar in structure. Both broad spectrum. Oxcarbazepine is the newer agent of the two. It's the better tolerated one, so it's probably preferred over carbamazepine. Carbamazepine isn't used quite as much for epilepsy anymore. It's used a lot more for things like neuropathic pain, bipolar disorder, and things like that. Other indications. Cons, so side effects, there's a number of them. Drowsiness, dizziness, some blood dyscrasias, category D in pregnancy overall. These are also both cytochrome P450 inducers, and especially carbamazepine. Oxcarbazepine is not as bad, but carbamazepine is again one of the other ones. So carbamazepine and phenytoin are definitely two to remember as strong CYP system inducers that are relatively commonly used. They're both dosed multiple times a day, but they have different formulations that can get around that. And then absent seizures, these are basically contraindicated because they can actually exacerbate that particular type of general seizure. There's a bunch of other broad spectrum anti-epileptic drugs. The only one I want you to know on this slide for this lecture is zonisamide. Just bold that one quick. It doesn't like it when I do that. Whatever. Okay, anyway, you guys got the point. Zonisamide is a newer agent that got approved again for partial, and it's not really approved for generalized, but it's been used fairly frequently. It's somewhat well tolerated. It does cause some anorexia. It has like a sulfa moiety on it, so people who are allergic to sulfa drugs might have an interaction or a reaction to it. The other drugs I'm not going to spend any time on really, other than to say they exist. There's a weird drug called ethosuximide that's really only indicated for absent seizures. Eventually, you could go down the pathway far enough where you end up with somebody on some sort of barbiturate or a benzodiazepine. And we're going to talk about those in the sedative hypnotic lecture. They're sedating, they're controlled substances. You build up a tolerance to them over time. Very poor choice for any chronic therapy. And so you probably won't ever see, hopefully you won't see patients on this for long-term seizure management, but it is like the last line therapy. So I thought I'd throw them in there and we'll come back to them. But felbamate, primidone, I don't care. You know those two. Not that they aren't used, they're just much less common. There are some AEDs for partial seizures only, and again, the only one I want you to know is the first one here. It's Coaseamide, which is actually a pretty common drug. It comes as an IV formulation too, which is nice. It is a controlled substance, which is sort of unusual, and it doesn't really have a lot of drug interactions or side effects, and it does have some interesting emerging evidence in more generalized seizures, so I don't know if it'll be useful more as a broad spectrum AED, but for now it's pretty much stuck to partial seizures. The other ones, again, get varying use, not super common, and I don't care that you know them. Okay, monitoring levels. So for a lot of AEDs, we can get a level on, and the reason is it's really important to figure out if somebody's compliant, because you really want to know if they have come in with a seizure or they've been having recurring seizures, is it because the drug's not working or because they're not taking it or the drug's not high enough level in their body? Now, most of the newer agents have really broad, wide therapeutic indexes, so we don't really need to think about dose adjustments from that perspective. You basically just follow the recommended guidelines, target a certain range, dose it up, and once the seizures are controlled, let it go. With other medications, it could be a little trickier. So this is phenytoin again. Remember, it's not a linear response. You end up increasing the dose. You substantially increase the plasma concentration. You can get trough levels on pretty much any anti-epileptic drug, but it doesn't tell you a lot. So again, if let's say you get a Khepera level on somebody, well, if it comes back within they'll give you a really big range of what Khepera level should be. And if it's on the low end or the high end, you're like, well, is that toxic? Is that subtherapeutic? Well, we don't really know. Basically, it's been shown that anything within this massive range of Khepera is therapeutic for patients, generally. So yeah, if it's on the low end, maybe you want to increase the dose. On the high end, maybe you want to decrease it, but there's no real science to support what you're doing. So that's where levels are basically only used for compliance for the new AEDs. And by newer, I mean basically levetiracetam, lamotrigine, valproic acid, and the oxcarbazepine. The only one you'd really get a level on regularly for therapeutic purposes and to make sure your dose is going up correctly is phenytoin. That's the only one we're using regularly. There might be some other exceptions to that, but for common drugs, that's all you need to know. Gabapentin and pregabalin were both designed as anti-epileptic drugs, and there is some actually evidence that gabapentin especially might be a good choice for especially elderly patients who have partial seizures only, but they aren't broad spectrum. They won't work for a generalized seizure, and they're actually pretty weak overall as anti-epileptic agents. So why do I talk about them? Well, gabapentin is probably one of the most commonly prescribed medications I see. I bet it's easily in the top 10 or top 20 of prescriptions written. Maybe I'm wrong on that, but it's got to be pretty close. And it's used all over for tons of different indications. So most commonly, nothing to do with epilepsy. You've got neuropathic pain, so fibromyalgia, diabetic neuropathy, postherpetic neuralgia. other pain syndromes, restless leg syndromes, anxiety, adjunct for a variety of psychiatric conditions, depending on the institution. I worked at the VA. Well, it didn't work. I did rotations at the VA. They really like gabapentin for anxiety and other types of psychiatric conditions. Pregabalin is basically just an analog of gabapentin. And is it better or worse? I don't know. They're about the same. But pregabalin is a controlled substance. So that's the biggest difference to know between the two. Otherwise, they're essentially used for the exact same indications. Both medications very well tolerated for the most part. Once you get higher doses, people get sedated on them, but that's about it. There's lots of rumors. Every year I hear people say, oh, this is going to be the year that gabapentin goes controlled substance. Still hasn't, still isn't, and I still haven't really heard if that's going to happen or not. So I think last year at this time I heard from our outpatient manager that, yep, it's going controlled substance for sure by the end of 2019. So make sure you guys have a plan. And here we are with no controlled substance plan. So I don't know. We'll see. Why people, I should just say this, why it's a controlled substance, I don't really know. I think for pregabalin, sometimes during clinical trials, especially for these antiepileptic drugs, people are reporting mild euphoria occasionally. You might get a handful of patients in the clinical trials that do that, and for that reason they say, well, it might have abuse potential, so we'll slap like a C5 on it, which is the lowest tier of controlled substances. So they're saying it's very unlikely to be abused. Problem with doing that from a logistics perspective is you have to document and control everything and make sure access is regulated, and it's just very complicated to dispense controlled substances versus regular. Not that that's a reason not to use them, but it just makes everything a little bit difficult, and there's not really a great explanation for why exactly that's the case. So anyway, that's my little story for the day. There are a bunch of newer antiepileptic drugs that have come on the market in the last couple of years, and they're all listed here. I won't test you on any of these because I think this gets really into the weeds, because a lot of these are brand name, they're expensive, and if you're working, I think it's better off just to focus on the basics. So for this lecture, really, focus on the big five that I had slides on, and then know a little bit about Coaseamide, and what's the other one I'm forgetting already? Enzanisamide, there we go. And as far as these drugs, just know that they exist. You'll notice some of them have kind of similar names to some of the things we talked about. So brivaracetam is like a Khepera analog, supposedly more potent. We'll see how it gets used. It's actually a controlled substance too, so another one that's got a controlled label on it. The other ones we get seen to varying degrees. We see a few patients on Onfi. I'm a bad person to talk to about how common these are, though, because we, again, have a big epilepsy program. We have a big neuro unit, so we use quite a bit of AEDs compared to maybe the average hospital. But certainly I do see some of these being used here and there, but not really common compared to the ones we've already talked about, which these probably represent like 1% of what we dispense for AEDs, whereas the others represent the 99%. Okay, so for generalized seizures, your treatment plan is what I've already talked about. I really think lamotrigine and levetiracetam are the two drugs you should consider getting somebody on as initial monotherapy, with divalproic acid, topiramate, and zonisamide kind of being the second ones based on general tolerability. You can cross taper to another broad spectrum AED if that's not fully effective or drug once it's fully titrated, or you could add something on. So let's say you got some response to the lamotrigine and the patient tolerated it really well, but they still having a seizure every once in a while, you add something else onto it. So that'd be phenytoin, carbamazepine, or maybe one of these other ones. And again, you can combine all of these. So you could be on levetiracetam and lamotrigine. So maybe that's your pathway there. But however you want to do it, there's no real specific instructions. It's more or less how you think the patient's going to respond. So for example, like I wouldn't prescribe lamotrigine to somebody who's got really poor compliance because you're going to have to retitrate them all the time. I wouldn't prescribe levetiracetam to somebody with a really unstable psychiatric history. I would consider topiramate for somebody who has a really high functioning job and needs to be able to focus and listen and be present regularly. So that's things to consider with these different medications and their side effects. The question comes up: can you ever stop an AED? And actually, there is our recommendations around doing this. And basically, 2 to 4 years of being seizure free, you can consider stopping the AED and slowly tapering it off. However, you certainly want to consider the risk versus the benefit. How hard was it to get that patient controlled? What was the origin of the seizure to begin with? Those are all things to think about. When you're considering stopping. A lot of patients will just be on these for life, but certainly there are actually studies to support that people can get off AEDs and be seizure free after that. treating partial seizures is fortunately not that much different. Carbamazepine has a little bit better evidence as a first-line therapy for partial, and you generally stay away from the more toxic broad-spectrum agents. So valproic acid and phenytoin have less use. Not to say they can't be used; they certainly could be, but we generally don't use them. And it's basically the same process: cross-taper, titrate, add another agent. Consider your partial-only agents that we talked about. I don't care, about absence seizures. They're too rare for us to care about, and it would be a specialized thing. Basically, you use essentially the same drugs. You don't use this drug called ethosuximide, which I barely talked about, and then you don't use these drugs either because they can actually aggravate the symptoms. So that's just that. Quick discussion on special populations. So pregnant patients, the newer antiepileptic drugs are preferred, but generally you don't change anything. So the risk to the developing fetus, if you have a seizure, is much more substantial than any risk that most drugs would pose. So your first choice, if you have the option, is lamotrigine or levetiracetam. Those are probably the best tolerated in pregnancy. I know I said lamotrigine is the first line, and there's some evidence that maybe more evidence favoring it, but generally speaking, levetiracetam is thought to be quite safe in pregnancy as well. Second choice, carbamazepine, oxcarbazepine, zonisamide. Third choice, phenytoin, phenobarbital, and topiramate. Basically, the one you really want to try avoiding using altogether is valproic acid if you can get around it. Most studies show no link to birth defects with these agents. And the thought is that if you can control the epilepsy better with a larger therapeutic index agent like lamotrigine, levetiracetam, or oxcarbazepine, then you're going to have better seizure control. Is going to lead to better pregnancy outcomes overall. There's a 4 to 6% risk of fetal malformations. Early gestational exposure, higher doses, and polypharmacy are thought to be contributors to the people who have epilepsy and who have fetal malformation reported incidents. Children, pretty much all drugs can be used in kids. Dosing and kinetics will vary significantly. We'll talk about child epilepsy, but we'll talk about child dosing in the summer modules. Lennox-Gastaut seizures are rare childhood seizures revolving around neurodevelopmental issues. Drugs aren't really helpful. I don't really care anything about Lennox-Gastaut, but you might hear it come up every once in a while. It's a pediatric thing. Brand versus generic. I bring this up because there was some legislation presented to the Minnesota State House a while ago that was basically a group of people trying to say that they wanted to make it law that if your doctor writes for, or PA, I shouldn't say doctor, if your prescriber writes for Khepera, for example, that you have to prescribe Khepera. Now, most places under law, well, I shouldn't say most, under federal law, a pharmacy can substitute whatever you prescribe for. So if you write Khepera on your prescription, they can dispense generic levetiracetam, and they will dispense generic levetiracetam unless you prescribe it as dispense as written or DAW, which you guys have probably learned at this point. Normally, this isn't really a big deal, but there is a variance possible between generic formulations. So what I'd be more concerned about maybe is if you had somebody slightly unstable is switching between formulations. So if a store, this happens to us all the time, we're always trying to get the cheapest manufacturer, and our wholesalers are always trying to get the cheapest product in. So they might have one brand of Khepera one week, and then we get another brand of Khepera the next week. Very common. So switching is really pretty common in a lot of situations. So that's probably the bigger risk than going brand versus generic. The brand's not going to be any more effective than the generic. So anyway, I want to make sure that that's just discussed, because sometimes in the AED world, they do like their brand names more so than really any other specialty out there. So you might come across that, especially if you do like a rotation in an epilepsy clinic or something like that. Most of the newer AEDs have gone generic in the past 5 years, so really don't have a lot of brand names out there anymore, with the exception of those newer agents on that slide I told you about. So for the most part, the new products are bioequivalent. They are generic, and they're a lot more affordable than they used to be. Okay, that's about all I have to say. There's not really any evidence or supported claims that brand or generic is a big difference. It makes a difference when you're treating seizures. All right, some agents reported to induce seizures. I don't care this for the exam, but this is a nice little table just to keep in your back pocket in case you come across any of this stuff. Some of the drugs out there are more likely to cause seizures, either just generally or an overdose. Most of these would be an overdose situation where you'd see it. And that's all I've got for you. in this module, and that's